CataractCoach.com, the Best of Cataract Coach course from the ASCRS in Boston 2024. We'll have a Q&A for every one of these for the audience, so if you feel like it, jump in. All right, case 2, posterior polar cataract. We lost our sound effects. It's supposed to go like, da-da-da, cataract coach.
We can just do that.
We'll do it.
Okay.
So here's posterior polar. So already this was in my schedule, it was booked as PSC. And I'm like, wait a minute, that's not PSC. So how do you know posterior polar versus PSC?
When you look at the slit lamp, you can see.
Oh, I know.
Do you examine your patients
I was just
preoperatively,
gonna say
Doctor?
Yes, kind of.
Okay, just checking.
Of course I do. So here, getting the rexus done. Now here, I really want to make sure I have a beautiful rexus because, studies from Osher and Vasavada show that it's a much higher rate of PC rupture in these cases. So what's most risky here? There's the Osher's reference. Rexus, hydrodissection, hydrodilation, nucleofractus. What's the risk here?
Dissection.
B, hydrodissection. You should never do a hydrodissection.
How about just a little bit till the wave goes right up to the opacity? Can you do that too?
No.
No?
I do a mild visco dissection up until I do a visco. I don't even bring a BSS cannula into these eyes. I do a visco delineation and I do a visco dissection, only flowering to the part of where the posterior polar cataract is.
Oh, I like that word, flowering. So like all the quadrants sort of comes.
See, I'm not just a pretty face.
So, which viscoelastic are you using with this? A dispersive agent?
I'll use a dispersive.
Like HPMC, hydroxypropyl methacellulose, or you use like a Visco? Or
Visco. I use Visco.
Okay. And you do the same thing then?
And if I can't even delineate the nucleus up and out and sandwich the epi down while I'm removing the nucleus, it depends. So I try to take posterior polars in early as possible because if the nucleus is dense, and I've had it where you've had a totally white cataract that walks in and you go and you hydrodissect and it drops, right? And that's an undiagnosed posterior polar because you just never saw them at a posterior polar state. But so earlier is better on these cases.
I just delineate and not dissect, get the nucleus out, and then do the visco-dissection of the cortex, just like Rosa said.
I think it's a great way of doing it. So
I flower it, even the cortex, I'll flower it and I take that piece off last.
I like that. So here's I'm doing the delineation. I'm trying to stay within that rexus because I just don't want it to go hydrodelineate. I want the delineation only. I want that golden ring. And then like you said, hopefully the patient on the younger side, which it looks like from the eyelashes, I want to get this endonucleus up out of the bag there. Well, there's the TV commercial.
You can tell the age based on the eyelashes.
Can't you look? It looks like a younger patient.
It could be on a latanoprost-like drug.
Yeah, I guess.
They could be fake.
So here I'm just dialing up, getting that endonucleus, kind of digging it out of the bag a little bit. I don't mind leaving the epinucleus and the cortex back in the bag, but I want that endonucleus kind of up and out. And so now I'll go inside here and emulsify this thing. I'm also weary of doing like too much nucleofractus in the bag because I don't want to put stress like I'm trying to split two halves. Let's say if you're doing a divide and conquer, you try to split two halves. So here the endonucleus comes out. You can look way in the back in the posterior. You can see there's still the opacity, so I'm happy there. Any other pearls for this part?
I mean, if you're concerned at all, you can, instead of using a second instrument, you can, well, so first of all, stop there. Oh, you can't. But I wouldn't have come out of the eye with the phaco. I would have injected viscoelastic at that point in time.
In fact, I may just do that. I'll show you. So here, use the coaxilated generative cortex, use bimanual cortex, visco-dissection, what you talked about.
Yeah.
Now, could you perform hydrodissection?
No.
Still no.
No, but I also I don't want that. So remember, even when you've got a posterior capsule rent, if you decompress the anterior chamber, that rent's going to extend, right?
Right.
So even in these cases, if now you come out with phaco and that capsule comes up, it may break in its area of weakness. So you never want to let the anterior segment
That is such an important point, and I've learned that the hard way. So again, reiterate her point, don't let the capsule come up. So don't flatten out the AC because that posterior polar opacity, just allowing the capsule to float up is enough to rip it wide open.
Yeah.
So that's a really great point here. What about for the nucleofractus technique? Any technique's fine? You don't mind doing chop in the bag? Or you still want to get it out of the bag?
I don't mind doing chop in the bag. You can do it if you do a gentle chop. You don't want to push down. You don't want to do that. But if you can get even a heminucleus out, you could even go back and do a sculpt and then do a stop and chop if you want to. Because really, as long as you keep the bag full, the chance of that breaking is a lot lower, okay? So keeping the tension on the bag is important to be full, not a capsular tension ring, but just to be full. So
don't let the AC collapse, basically.
that's the most important.
So yeah, I'm gonna take your advice here. Look, see, I was listening, I listened last time. So now we'll inject the viscoelastic, not let the AC collapse, and now I'm gonna do the visco-dissection you talked about, the flowering technique.
I know,
Learned something new today.
we gotta write it up.
The flower, it makes sense though. But yeah, I'm just going in all different quadrants with a dispersive viscoelastic, not too much pressure, and just kind of digging it up, and I think that should be pretty good. And now, are you going to put the IA probe back in here now, or are you going to put the phaco probe?
IA.
Yeah, me too. So, and even if it gets stuck, I can just use the spatula or something else, second instrument, to kind of push it down the port. But now I'll take the rest of this, and I'm pretty happy here. Now, for lens choices, let's say the bag looks pretty much intact. You can put any lens you want?
Yep.
I would do a one piece.
A
very gentle.
Is there a reason why I like the one piece?
Because it's gentle. As
Oh, so the way it opens up. So
yeah, not like a three piece that goes boink into the bag.
So deliver it basically closed up into the bag and then let it slowly open in the bag. All right, very smart, for sure.
You can always inject whatever lens you want, again, into the AC and then put it in slowly into the bag as well, if you're concerned.
All right, so here comes the last bit of it. I'm looking carefully. I'm always looking back there like, oh boy, now what? Now what? What did I do wrong? Anything?
Perfect.
Oh,
you did a great job.
Better to be lucky than good, right?
So do not polish this capsule, though.
Yeah.
You sure? But there's a little smudge right there.
Do not polish this capsule.
Oh, you did. Okay, wait.
Do you polish the capsule? A, use very low vacuum. B, mechanical capsule polish. C, gentle hydro polish. Or D, you'd be crazy to touch the capsule.
D.
Cuckoo bananas.
Yeah, I mean, we already saw the first case, right? But especially here, because we know that posterior capsule is going to be thinner than a typical capsule, right, in these posterior polar cataracts. So here, especially, you want to inject viscoelastic with your left hand and decrease the irrigation, so fill up the bag before you come out with the IA tip.
Fantastic. I love the advice there. But yes, you don't want to touch the capsule. What about anterior capsule rim polishing? You fill the bag with viscoelastic. You can use the mechanical polishers on the undersurface of the anterior rim, not the posterior capsule. Is that okay?
Fine. Sure.
You let me get away with that one?
Knock yourself out.
If you're standing in the back, there are seats up front here. We're going to have every seat full. Yes. So I agree with you on this one. I'm also going to put that single piece acrylic lens in the bag. And to me, that's going to be the easiest choice. And like you said, I want to put it in very gently so that as I deliver it, it goes in the bag all folded up and then slowly opens up. And then I don't want to manipulate it too much. I don't want to rotate it around. Hopefully, we'll see. I don't think it's a toric lens. Hopefully not a toric lens. If it is, I want to get that toric lens pretty close to lined up prior to the arms fully opening up. And we've learned that will make life a lot easier here. So here we go. Let's see what's happening next. Hope you like the format. It's an easy way of staying absolutely on time. So here you go. More viscoelastic like you taught me. So here comes a cohesive agent. Not going to overfill, just enough, and not come out of the eye. And then now, for the lens, we're going to put that single piece lens in here. And I'm not going to polish. You can see the undersurface, the anterior rim. Arguably, you could say, well, you could go in there and polish it a little bit, but I don't want to do that. So again, we're going to do single piece acrylic lens in the bag. Would you ever put a CTR in a case with a posterior polar? No. What if there's a posterior polar, but you had like zonular loss too? Would you put a CTR, or you think that's too much force?
You could put a CTR in, but make sure you guide it. Like you've got to have a Sinski or something in your second hand. Hold on to the little hole of the initial CTR and guide it in there slowly. Don't let it snap into the bag.
So you're doing like a Sinski in the left hand, injector in the right, but you do it differently. You like only forceps.
I just inject, but keeping the CTR all the way over to the left, so then as it's coming out, it has an extended range, so it's very soft. It's not very
So you're going more tangential, not
exactly.
Not
That's
radial.
Josh Teichman taught me that. Exactly.
And that makes a lot. In fact, a good thing you talked about CTRs, because we got a case coming up where I got a quiz for you.
And just at this point, I'd like to make the difference between, because I do a lot of cases that are post-injection by fellows or residents, and so sometimes you can see that the posterior capsule has been compromised. The difference there is that if you wait a couple of months, that posterior capsule will scar, so it's not as thin inherently as a posterior polar. So it's a little bit of a different animal. Even though I do the same sort of thing, I'm not so worried at the end that it's going to rupture, because if there is a scar, I'm going to have to yag it after because it's not as thin as this.
Okay, so yeah, I'm using your advice here. Boom, single piece acrylic lens in the bag. Luckily, it's non-toric. I'll just get it where I want it. It opens up pretty atraumatically. And they're, high power lens too, 27. So small eye, hyperopic eye. Seal up the incision here at the end too, while the eye's still full of viscoelastic, because like you said, I don't want to cause any flattening of that anterior chamber. So take out our viscoelastic here, we've sealed that incision, and I'll even just use BSS in the other hand, just to make sure I don't flatten out the eye too much. So get that nicely hydrated. Yeah.
Another thing you can do is put an air bubble in
nice.
the AC so that you don't flatten the AC. Because when you use BSS, oftentimes it still shallows.
Right.
But if you put an air bubble, it will not shallow.
I've never even thought of that. Yeah, an air bulb at the end of a routine cataract case is common in other countries. In the US, I don't see it too often, but that's a nice technique that we can use. Any audience Q&A, if you do, step up to the mic. We have Q&A built in here because of feedback from last year where they said they wanted Q&A. Yeah, jump up there. You got 31 seconds.
Talk fast.
For some cases like this, sometimes I make a second paracentesis just in case
Yep.
you need to do a retractment by manual. Thoughts on that?
I love the idea.
Great.
A second pair, no harm, plus then you can do a bimanual IA. I like that.
Yep.
We had another
How
comment?
often do you see the fishtail sign that we all learned about? I never see it with these posterior polars. And they're posterior polars.
Right. Panel, I don't...
No, I haven't seen it.
Yeah.
Well, that's the difference. Now we learn by videos, not by reading stuff in books. This is totally different. Honestly, it's a brave new world.